Our second speaker is Dr. John Graham, who was a retired consultant physician who practiced for many years in Macquarie Street and at Sydney Hospital. It was through his long-running interest in the running saw, that is, public hospital administration in New South Wales, that he became known, as it were, to the CIS, an association we were able to forge a few years ago when we published a report by John on the role and function of hospital boards. This report has formed part of the larger body of work that we've been doing here on hospital governance and administration. But hospital administration is only one of the health issues John has retained an interest in, and these subjects include national health security and, of course, preventive health.
My name's John Graham, and I had a professional life as a consultant physician in Sydney, working at 5 different public hospitals. I've been retired for 4 years, and so I sort of wonder why the CIS has invited me to still be talking on matters medical. But I do thank Greg Lindsay and Jenny and Jeremy Samet and Helen and Megan and Kiri for giving me the chance to speak to you today. It's a pleasure to join Helen on this stage and to put some challenging comments out in front of you. If there is anyone from the press here, and I doubt it, but if there is, I'd like my comments to be off the record, but I'm more than happy at the end of the evening to talk on the record about individual matters. Helen's done very well in her monograph to throw light on wastes in the health bureaucracy. The spending of $872 million by the Australian government on the Australian National Preventive Health Agency since 2009, in my view, represents a monumental waste of money that could have been spent on research into cures and preventions of many of the serious disorders that doctors have to manage. The spending of so much money on assessing performance targets and dreaming up useless preventive health goals has, in my opinion, been very wasteful. If the community is going to commit a lot of money and significant resources on educating our young people to become doctors, that should be the end of the story. Let the doctors do their best to keep the community as healthy as they can. And before I leave that point, in light of some of the recent comments in this state, I would like to say categorically that nurses should concentrate on nursing and stop trying to be junior doctors. If a nurse wants to be a doctor, he or she should undertake a medical graduate degree. The February 2015 message, which came to me in the post only yesterday from the AMA president, Dr. Brian Owler, starts with, and I'll quote, "Spend time with any group of doctors and it quickly becomes apparent that their focus is to achieve the best possible outcomes for their patients." End of quote. There will obviously be some rare exceptions, but you certainly don't need to employ literally thousands of bureaucrats to monitor whether the doctors are doing what they were trained to do. What people need to understand is that medicine, and here I include surgery and all the various clinical disciplines, is a science-based art form. And as such, it's almost incapable of being sensibly or beneficially reviewed by outsiders. It's important to remember that no doctor can keep any patient alive forever. Given that mortality is inevitable. Any caring doctor should try to ensure that all preventions and attempted cures are worthwhile. Costs versus benefits need to be assessed. Are we achieving desirable outcomes of enabling human productivity and enjoyment of living? And so on. Diseases and injuries, in my view, fall into 4 categories. Firstly, preventable. This is the best, especially if the prevention is inexpensive. Secondly, curable, second best, but often expensive. Thirdly, treatable, nearly always expensive. And fourthly, incurable, where supportive management is the only care available. Some preventions have proved to be inexpensive and massively worthwhile. Examples are the Sabin oral vaccine to prevent polio, a wicked disease, fortunately hardly seen in Australia, and apart from, I think, the African continent, hardly seen anywhere in the world these days. The cowpox vaccination, which eradicated smallpox, so that it just doesn't exist in the world anymore. The early use of penicillin for streptococcal sore throats to prevent rheumatic fever and its consequences on heart valves. Eradication of mosquitoes to prevent malaria transmission and other infections. Is prolongation of life a worthy goal? In my view, probably not. The result of all the good efforts in reducing tobacco usage, managing diabetes, reducing blood levels of LDL cholesterol, reducing blood pressure, has certainly reduced the chance in any 1 year of dying from heart attack or stroke. But in the end, is that a good and favourable outcome? Death, which comes suddenly and out of the blue, is certainly the finale which I and virtually all of my colleagues are hoping for when our time is up. If we go on preventing or deferring the onset of preventable or treatable diseases that would otherwise be associated with sudden mortality, we simply increase the chance that the essentially untreatable chronic diseases will then become everyone's lot. And is that desirable? Here I refer to the legacies of ageing, which undeniably include immobility, deafness, failing vision, especially with macular degeneration, and dementia. It is worth looking at a 2013 report in the world's best medical journal, the New England Journal of Medicine from Boston, entitled Monetary Costs of Dementia in the United States. The estimated prevalence in 2010 of dementia in persons in the United States who were older than 70 years of age was 14.7%. Women are more prone than men to dementia by a factor of 3 to 2. The monetary cost per person that was attributable to dementia in the US in 2010 was in the range of $41,000 to $56,000 US dollars, and the cost to the United States as a whole in that year was estimated at between $157 and $215 billion. And that is just the financial cost. It doesn't even look at the emotional cost of having a family member with dementia. Until the researchers and doctors have cures or preventions for dementia, for deafness, for blindness, for immobility, what are we doing when we try to prevent anything? Diseases and trauma events that are preventable or curable fall into categories where the cost is either cheap, like the Sabin vaccine, fairly cheap, like proton pump inhibitors for people who get heartburn or have peptic ulcers, modestly expensive, like stenting for coronary artery disease, quite expensive, joint replacements for osteoarthritis, or really expensive, like liver transplants for chronic hepatitis, the pharmacotherapy for AIDS, hemodialysis for renal failure. And so governments, acting on behalf of all of us, will have to make some pretty harsh assessments of how best to spend a limited supply of dollars. I can only wish them all well. Congratulations, Helen, for your paper. Congratulations to the CIS for getting the debate underway, because this is a really important debate that we need to have. And thank you all for listening.